Okay. Good evening, sir, dear doctors and honorable guests. I am Ahmed Saleh, product manager, Farco Pharmaceutical Industry, and we are now together witnessing the opening of the first virtual international conference in Egypt, sponsored by Farco Pharmaceutical Industry. I am delighted to welcome all professors who honored to us with supervising the scientific meeting, and we hope that cooperation will continue in the near future. Now we can show the Farco movie about 1 minute at Egyptian for the largest Egyptian pharmaceutical industry, so you can watch it.
So start, Dr. Ahmed.
Okay. Thank you, dear doctors and guests. And now we present Dr. Mohammed Shireen, CEO, Commercial Operation of Farco Pharmaceutical Industry.
Good morning and good evening to everyone. It is my pleasure to welcome you all with us here today. Our guest speakers from Brazil, Italy, Germany, Ireland, and Egypt, and our well-respected physicians and attendees. Thank you for joining us. I hope that everyone is staying safe in these difficult times. I would like to assure you that Farco is continuing its manufacturing at full capacity, and we aim to have continuous supply of all of our medications. Now, who is Farco? Farco is the largest pharmaceutical manufacturing company in Egypt. We're a group of 6 manufacturing companies that together produce the largest number of units to the Egyptian market, and we also export to more than 50 countries around the world. In Farco, we are aiming to invest and grow our ophthalmology division. We have a strong pipeline with 2 new launches this year. We're also investing in machinery, so we'll have a new machine in a few weeks. It was planned for Q1 this year, but due to the circumstances, we've had to delay it. But very soon, we'll be able to manufacture an estimated more than 25 million units per year. So at Farco, we have grown through our quality excellence in manufacturing, and we aim to continue doing so in new fields that we enter, like ophthalmology. Once more, I'd like to thank you all for joining us and wishing you all the best. Thank you.
Thank you, Dr. Mohammed
Shireen. And now we start the scientific day. And before that, we must thank big thanks to Dr. Ashraf Armia, who spent a lot of time and work for organizing and supervising the scientific day. Many thanks, Dr. Ashraf. And we take the meeting, and I wish a more scientific day and fruitful meeting, inshallah. Thank you.
Thank you, Dr. Ahmed. Thank you, Dr. Muhammad. So we are going to start our day. I'm going to present. I am Dr. Ashraf Armia from Cairo, Egypt. I'm really honored today to moderate this event, which is for the first time live streaming from Cairo, Egypt. It's an international ophthalmology meeting about premium cataract surgery, which we heard since last day with Arthur Cummings with the Refractive Surgery Alliance. I can remember this from yesterday. This event is organized by Farco Pharmaceutical Egyptian company. It's nothing can stop us conducting science, even in the era of COVID-19 pandemic and our quarantine at home. Continuous medical education must be continued even if all the big international ophthalmology meetings have been cancelled. It's my pleasure today to have my dearest eminent ophthalmology friends from all over the world, Professor Ahmed Al Masry from Alexandria, Egypt, Professor Dr. Arthur Cummings from Ireland, Professor Dr. Detlef Holand from Germany, Professor Dr. Francesco Carones from Italy, Professor Dr. Sergio Canabrava from Brazil. We are now live for all ophthalmologists all over the world from Cairo, Egypt. Thanks again for Farco Pharmaceutical Company for supporting continuous medical education. So our first presentation will going to be by Dr. Ahmed Al Masry, how to select patient for premium cataract surgery. Your talk with you, Dr. Ahmed.
Hello, everybody. Can you hear me? First of all, I would like to thank you for allowing me to share with you.
Yes, we can hear you.
Perfect. This presentation about the selection of patient for premium cataract surgery. The time allowed is about 10 minutes, as I know. So I would like to stick to time. And it's a short presentation. It wouldn't take the 10 minutes, but it's a very crucial and important presentation because I feel that many points that many ophthalmic surgeons till now, they didn't, not there, but they didn't go in the trifocals and the multifocal IOLs. And again, my statement is to say is the talent of the ophthalmic surgeon is to discover the personality and the psychology of his patient as early as possible. So before implanting toric or trifocal IOLs, we have to select the proper patient to be sure that this patient has normal ocular surface, no dischoritis, no meibomian gland disorders, and the tear film layer is okay. And then topography or shine fluid imaging, and knowing the posterior corneal power also is mandatory for all these patients. Accurate biometry is one of the key points to have satisfied patient. Lastly, but not leastly, normal macula and OCT macula should be done for all these patients because many times we can find hidden pathology in the macula that will change the whole thing after the surgery. This is simply a survey that had been done and published in Eye in 2019, asking the ophthalmic surgeons which intraocular lens would ophthalmologists choose for themselves. And as you see here, that the toric monofocal, if the patient is more than 1.25 diopter astigmatism, took about 65%, 65.7%. I can't find my presentation. I don't know what happened. Can you hear me?
Yes, I can hear you well.
Yes, thank you. And again, with the screen, the slides.
Yes.
Yes. I don't know. Yes. As you see that 65.7% of the ophthalmologists, they prefer the toric monofocal lenses, while the toric accommodative lenses is only 3.2%. So there is still small number of ophthalmologists that they agree to put for themselves the trifocal or the multifocal, especially the toric ones. So to go deeper, we have to understand more what's the facts that we should know about the premium IOLs. First, don't promise patients with life free of glasses. The patient should accept that at a time he may need glasses, whether for near or for distance. The multifocal, trifocal patients are very sensitive to posterior capsule opacification. So once you see any cells on the posterior capsule, you have to do YAG laser, which makes a big difference for them. Spend more time with the patient. It's the patient's right to know about the toric and the trifocal IOLs, and the cost-benefit effectiveness is the patient's choice. It's not your choice. Don't say this patient will not afford the trifocal or the toric IOLs, but you have to tell the patient about the trifocal if he's a good candidate for that. Usually start with the hyperopes. They have the best results, followed by the high myopes, emmetropes, lastly, and the least satisfactory group are the low myopes, because they have the natural reading without glasses, so they are a little bit comparing between the new reading without glasses with the trifocals with their old way of reading, so they are less satisfied with the trifocals. The accepted indications for presbyopic IOLs is to not only to restore the clear vision following the cataract surgery, but also to correct the presbyopia and any associated degree of refractive errors. And this again opens the point is whether the toric trifocals are a good choice for these patients or only the trifocals. Maybe the next two slides are the most important for the audience to concentrate in, and they are quoted from my dear friend and colleague, Professor Ashraf, that we have to have 7 questions for every patient. Are you interested in seeing well without glasses? This is number 1. The patient's answer is yes. And the second is, are you interested in seeing well at near without glasses after surgery? And the patient answer is yes. You have to know that there are 3 zones that the patient should be asked about: the near zone, the intermediate, and the far one. And in which group of zones that the patient is satisfied more, or the most important one for the patient? Is it the group A, zone 1, 2, and 3, or the group B, zone 2, 3, and 4, or group C, zone 3, 4, and 5? And this will let you select whether the trifocal are the best, the extended depth of focus, the hydrophobic, the hydrophilic, and still the debate about which is which for the patient depends on the selection of these patients. Again, if you have, don't know why the slides are disappearing. Yes. If you have to wear glasses after surgery for one activity, have to wear glasses after surgery for one activity, which one you will be most willing to use? The reading, the computer, or the driving? And do you accept the halos that you may see at night after the surgery for a while or not? This is a very crucial question, because the night drivers definitely are contraindicated to do trifocals for them, because more than 80% of the patients, they suffer from halos around light at the beginning. Still, the cortical adaptation will take place. The pre-last question is, if you could have good far and intermediate vision during the day and night without glasses, but you might need glasses for reading, do you accept it or you do not accept this option? This is a very important point, especially for the patients who are putting the extended depth of focus, because as you know, in the extended depth of focus, the near point is a little bit away, more than the 20 or 30 centimeters, so they may need near glasses at that time. And the last question, which is very important, the personality of the patient. Is it an easygoing personality or perfectionist? Please don't put trifocals for any perfectionist. Spend some time talking with patient about the spectacle reduction rather than total spectacle independence. Discuss and convince the patient with the bilaterality. Bilateral trifocals is very effective, more than putting unilateral, and all of the time prepare the patient for bilateral trifocal IOLs. You should insist of 10% chance of glasses or laser visual correction 3 months after the surgery. The preoperative considerations, the patients who no longer desire to wear glasses, the age, the younger the patient, the better the results, the functional and occupational requirements, the general alertness. The patient should know what he's putting and what he's doing and what he needs. What are the needs for this patient? Is he alert for what we are talking about, or is not alert? No ocular pathology, of course, patient's visual demands, expectation for the near vision needs, and the quality for bilateral implants. Premium cataract surgery, the keys of success are the accurate biometry. You have to select the recent formulas. Please do more than one formula, because accurate biometry is one of the keystones for good results and patient satisfaction. Of course, the surgical technique, the topography, normal ocular surface, and normal macula. The preoperative exclusion criteria include subjective exclusion. The patients with unrealistic expectations, please don't try to put for them any trifocals. Those who want to wear glasses, of course, they don't need to put trifocals. The occupational light drivers, they suffer from the trifocals because the halos at night may bother them. And medical exclusion, of course, any pre-existing ocular pathology or previous refractive surgery, which is now a debatable point because we started to put trifocals for patients after refractive surgery. The extended depth of focus doing better than the usual trifocals for these patients with very accurate biometry. Lastly, be realistic with your premium cataract patients, correlating cost-wise and visual expectations. And lastly, stay home, stay safe, and thank you so much.
Thank you, Professor Ahmed, for this wonderful presentation. This means that to have a premium cataract surgery, you have a premium pre-op full examination for the patient to receive this premium quality of service.
Sure, Ashraf. We have to have full investigations starting from the topography, measurement of the dry eye, and OCT, macula, and optic nerve to be sure that everything's okay. And lastly, the patient personality. He should be an easygoing personality, not a perfectionist.
So not everyone is coming to you asking for a premium cataract surgery. You accept what the patient wants.
Sure. I tell the patient that this is more suitable for you, or this type of IOL is suitable or not suitable for you. Depends on the
because
patient.
Usually the patient tell each other, my friend, my colleagues did when he's happy, and I want to be happy like him.
If he fulfills the criteria, of course, I'm going to put for him the trifocals. But if he doesn't fulfill the criteria, I'm telling him that you will not be happy with these trifocals because of so and so, even for his personality. Some
Yes.
patients, I'm telling them, you are one of the perfectionists that will not be so happy with this type of IOLs. But again, the recent types of trifocals are forgiving for this point because the adaptation, the cortical adaptation, is definitely better than the old versions. And these new versions, of course, are giving more better results.
Excellent. So thank you again, Dr. Ahmed Al Masry. Now we are going to have Dr. Detlef Holand from Germany. Do you hear me, Dr. Detlef?
I will turn my mic off.
Dr. Detlef, do you hear me? Dr. Detlef, do you hear me? You are still in? Yes, Dr. Detlef, you are with me now, yeah?
Do you want my presentation now? Ashraf?
Yes, I'm here.
Hello.
So you arrived, yes.
We skipped a little bit the numbers, so I thought I would be the fourth to speak. So
no, you're being the second. So now we are going to have Dr. Detlef Holand from Germany, from Kiel, a very nice city, as he always sent me the pictures of the city.
Oh, thank you.
We are going to, yes.
So
we are going to talk about how premium toric correction can make the patient more satisfied with this premium high quality technology.
I have to wait a little bit. It takes a little bit time until you can see my presentation. I hope you can hear me.
Yeah, I can hear you well.
Yeah. I want to talk to you about Toric IOL, and
yes.
I think very soon you will also see my presentation. I hope you can see it now. Hello?
Not yet. It's coming. It's coming. It's coming.
It's coming?
Yeah, it's just, yes. This is Dr. Ahmed Al Masry presentation. So, yes, yours now. I can see yours.
My first slide now. Okay.
Yes.
Great. So you can see also my financial disclosure on this picture. And I will start now, okay?
Yes, you can start.
Yeah, luckily, as we can see here on this picture, on this slide with these old Roman pictures, and the other picture you can see is from Jacques Daviel. It's from the 17th century. We are very lucky that we don't live in ancient time, but that we have all these modern techniques like femtocataract surgery and also like toric IOLs. But as we heard in the presentation before, we always have to ask ourselves if our standard of care is really as good as it could be. For example, in Germany, we have only 3 to 5% of patients who get premium IOL, including toric IOL, overall in all the cataract procedures that are performed. So I think it's very important that we all work together for the goal to change that and provide more higher standard of care for our patients. So what are the inclusion criteria for toric intracapsular IOL? First of all, as we already had before, is the patient's desire for more than standard care. So we really have to inform our patients before cataract surgery about all the options that we have. We start to consider toric IOLs if there's a regular astigmatism above 0.75 diopter. It has to be stable, and we always have to take care that there are no contact lenses used before at least 2 weeks before the examinations. What is getting more and more in our focus is that we have to take care of dry eye disease, because it can influence very severe our preoperative examinations. And if there is a severe dry eye disease or meibomian gland dysfunction, we have to treat that in advance, and we explain this to the patients, and they really understand it, that it's important for a very good post-operative result. We repeat examinations, and we all know why is it important, because wrong K readings and wrong axis result in under or overcorrections and in unhappy patients. And you can see on the right-hand side these two topographies. You can see that it's really different, and it's only 3 minutes behind one of the others of these examinations. We also have to inform the patients about possible rotations of the toric IOL, and even if it's very rare, and about residual refractive error. So how we do perform our marking, because of the fact that we don't have a microscope-based marking system. We use a RoboMarker, which is a very easy and precise. It has a single-use tip, and it has an integrated fixation lamp, which makes it really easy to fixate for the patient. The eye is really calm, and it only takes some seconds to proceed this. But most of our premium IOL patients, they also demand for femtolaser-assisted cataract surgery. And this is also very nice because in this procedure, we have the option of streamline. We can stream via VLAN the results of the Cassini, of the corneal topographer, directly into the laser. And the laser gives us the opportunity for steep axis marking of within the capsulotomy, as I can show you. And we have also the option for cyclotorsion control and compensation of it. The laser automatically compares a picture preoperatively with a myotic pupil intraoperatively to the intraoperative picture, and always compensates automatically the cyclorotation of the eye, which gives more precise results. And here you can see the concept of the IntelliAxis. There are two marks in the capsulotomy in the steep axis, and so you can easily implant the Toric IOL in the steep axis. Here, I hope the video will work. You can see how the capsulotomy with the marks is performed, and I hope at the end of the video you can also see these tiny little marks which help you. I think it's really good to see here in the capsulotomy. Yeah, it's really clear. Here, these marks really help you intraoperatively because they are directly in front of the IOL, and this makes the results very precise. I show you here some slide of a very good friend of mine, of Dr. Breyer from Düsseldorf. He allowed me to present this slide here. He had a very good presentation in Marrakesh at the ESCS Winter meeting, and he examined 77 eyes where he did the Toric IOL alignment with IntelliAxis, and he compared it with literature 1 year after surgery, and he could see that the alignment errors approximately reduced by half with this procedure, and I think that's very good data, and this is, I think, an excellent option, and it also shows the quality of femtolaser assisted cataract surgery, even in Toric IOL implantation. So what is important intraoperatively, the head position has to be perfect, that the eye is in perfect position to avoid axial mistakes. I always do very slow operation. We have to take care of a perfect overlap of the capsulotomy if we don't use femtolaser, where is it always like that? I always use a CTR because I think it's much better, and it also reduces the possibility of rotation. And what's also very important to do irrigation of the OVD behind the lens. So perhaps I can show you some data of a study we did recently. And it was a study where we checked our postoperative results with a new Toric IOL with a precision Toric of Alcon. It was a single surgeon study, and all the patients got their topography and the biometric examines with a Cassini. I meant for the K readings, etc. All the patients were marked with a RoboMarker, and all get the precision Toric. And what is special thing with this IOL, that in comparison to a standard Toric, you can see that the area in the optic where the astigmatism is compensated is wider. And this results in better results. So the in rotation, or if the position intraoperatively was not so perfect. So it allows a little bit of mistakes and even gives good results. So I already explained this. You can see the study design. It was a prospective study. And we included 30 patients and 60 eyes. And we allowed no other pathologies in the study. And here you can see the preoperative data. It was just normal cataract patients. And what you can see here 3 months postoperatively is that the uncorrected visual acuity and corrected distant visual acuity were absolutely comparable. So we have a very low post-operative refraction for far distance, which was desired before. The mean toric power of the IOLs was 2 diopters with a range from 1 to 3 diopters. So you can see also compared to other studies, we achieved a very good uncorrected distant visual acuity. Also, the spherical equivalent was compared to other studies about this IOL, and we were really close to our targeted refraction. So you can see here that with this new IOL, we really achieve very good results, and the patient satisfaction, the subjective patient satisfaction was also very good in this study. So let me just have, before I finish this presentation, have a look in the future. We all know, and we also talked about the FEMTIS in our other presentation some days before. And we know that this IOL has very good results regarding IOL rotation. And I believe that this IOL also will have very good results when we use it as a toric version, which will come very soon. And now, as you can see here, another thing which we really discuss a lot in our clinic, I think there are also new options for toric add-on IOLs because we have the reversibility with this type of IOLs. And so we can also start, from my point of view, to use it in toric IOLs in patients where we in further times haven't used it. For example, if there's a mild macular degeneration, or if there's a little bit pathological results in the endothelial cell count, or in slightly irregular astigmatisms, or after refractive surgery. I think there is the option with toric add-on IOLs. It's very good, and it brings a lot of safety to the procedure and to our patients. So I come to the end of the presentation. Best regards from Kiel, and I hope we see us all soon in autumn on conferences when normal life again is beginning. Thank you very much.
Thank you so much, dear Detlef. It's a very wonderful and very nice presentation, really. So you have 2 questions from the audience. The first question is from Anis. He's saying, what is the value of astigmatism to go to toric lens? Is it the same for the rule and against the rule astigmatism?
Yeah, we don't consider any difference if there's again or with a rule. Yeah, I think the most important thing is that you have really reliable results, that you repeat the examination, and I think the preoperative planning is the most important key step to have good results.
Okay, and another question he's asking, what is the incidence of decreasing the rotation when you are using the CTR? Did you find a difference between patient using the CTR and patient without?
Yeah, excellent question, but I have to say we didn't examine that because I performed it for years now, And I don't know, and I'm also not sure if there are comparable, if there are any studies regarding that. We just do an ongoing study with Morcha about the safety and efficacy of capsular tension rings, and perhaps we can do also a comparison then with that. But I use it in every premium IOL, the CTR, because I see less folds in the posterior capsule, and I think there is more strength in the capsule then. And so it's just my belief that it's a benefit for the patient to use a CTR. And even if I have to do an explantation later on, it's much easier if you have a CTR, and I think it's also safer. Yeah. And yeah.
Yeah, do you think the CTR decreases the rotation or decreases the incidence of capsular phimosis that we can make a tilt in the IOL that can lead to astigmatism in the future?
Yeah, I do absolutely believe that. And if you see a capsular phimosis of the anterior capsule with a CTR, it's always that it's quite regular, you know. It's just the phimosis goes straight to the middle of the IOL if you use a CTR, and then I think the lens tilt is less than if you don't use a CTR. Yes.
Do you use toric IOLs if you find that there is any instance of subluxation in the capsule? You change your mind?
No. If I intraoperatively and also explain the patient that if intraoperatively there is a loose sonula, then I don't use toric IOLs. Yes.
Another question from Manuela. She's asking about, did you notice any toric IOL rotation after 3 years?
After 3 years?
Yes.
Sorry, I don't have such a long follow-up. I see a lot of patients because I am now since 15 years in also my practice in Kiel, and we started so long ago with toric IOL. And I don't see patients who have big complaints, but this is only an impression, even after years, you know. But we all know that there can be changes in the astigmatism of the cornea within time. So it can be that after some time the residual refraction is getting higher, or there's again some kind of astigmatism. But I haven't noticed a rotation after a long time. And I think if the sonula are strong, you won't expect after the normal fibrosis of the capsula has established that there will be a rotation of the IOL anymore.
Two last very short answer questions. Do you notice any difference between the accuracy of the FEM2 and the RoboMarker? Yes or no?
Very good question. I always perform because I always want to be on the absolute safe side. Because sometimes if there is which is very, very rare, if there's a lot of suction during the FEM2 procedure, then I don't have marking. So I always do the RoboMarker, and then I do the IntelliAxis L marking. And so I can compare that very good, and they are always absolutely close to each other. And that's also very interesting because you can see that the cyclotorsion control of the laser really works quite good.
So my last question to you, did you find till now, after the Zeiss 700, a toric surprise post-operatively?
We use regularly in the moment more the Oculentis toric IOL, which is also plate haptic IOL, but we use also the Torbi of Zeiss. And the overall in our premium IOL patients, the number of patients with a refractive surprise is very low. And I think this is also because of the IOL Masters 700 we use regularly. I think this has improved the quality of refraction quite good. But as I told you, we have to explain all the patient in advance that there could be a refractive surprise, especially in high hyperopes and high myopic patients. But it occurs really seldom that we have to do a explantation of the IOL, or to have do a touch-up LASIK, or to put a additional add-on IOL because of a refractive surprise.
Thank you so much, Detlef, for this wonderful presentation.
Yeah, thank you very much for the opportunity.
Yeah. Stay with us. You are going to have a lot of questions. You have a lot of questions coming in the QA.
Yeah.
Okay. And okay. And now I'm going to present my talk today. It's about EDOF lenses, which is the extended depth of focus, which I used since more than 6 years now. And we don't have a lot of in Egypt, Cairo, but we have some, and we are waiting for another one coming in a couple of months. So I have no financial disclosure about my presentation regarding any of the brands I'm going to talk about. Extended depth of focus, it's an intraocular use of advanced optical technology that allows to increase the range of focus compared to standard monofocal IOLs. EDOF lenses enables clear vision ranging from far to intermediate distance, like the computer monitor. But close-up activities such as reading fine prints and precision work, patients treated with EDOF lenses may need to wear reading glasses. So how does the EDOF lenses work? It's bending the light entering of the eye from intermediate and far distance and focusing this light into a single focal point on your retina. This allows you to focus the object at a distance simultaneously, providing a good intermediate and distant vision lens through the lens. So what is the balance, the refractive target? Very important that you are aiming for a plano in both eyes, with a caveat of choosing the IOL power that is close to plano, on plus side for the dominant eye and the minus side for the non-dominant eye. In other words, if the IOL formers print shows that the IOL power option that would provide either minus 0.09 diopter and the other is plus 0.1 diopter, so I'm going to choose the minus for the dominant and the plus for the non-dominant eye. Very important in these premium lenses, counseling the patient to know what his needs and what the importance of to use special types for every patient. It's not enough to tell the patient that you're going to have a functional near vision. This it's not necessary for a term of they recognize. Very important to provide examples of what they probably will not be able to do with the EDOF lenses, like newspaper reading, the back of the pill bottle or bottles. Very important to discuss the possibility of halos, starbursts, and glare, which while much likely to happen with these multifocal or these EDOF lenses. Sometimes I consider mix and match for myopes. Myopes may become accustomed to removing their glasses to see the near, so they are accustomed for this when you remove your glasses. So don't make a surprise for the patient. So I address this by implanting an EDOF in the dominant eye first. Then I engage the patient with a conversation. I am telling him, if you are happy with this for the dominant eye, so why we are giving near vision for the other eye? So if the patient is good, it's very important, better near vision for the other eye. So I implant a low add multifocal with a plus 3.25 for the other eye. Push plus in the post-operative refraction. refraction in the patient with the EDOF lenses requires a unique approach. So it's important to work closely with the technicians and the co-manager optometrists to make sure that the patient knows what to expect. EDOF lenses love to gobble up minus. Very important to know this. So surgeons should start at plano and ask the patient better 1 or 2. The patient may ask for more minus. You must have this trial. For more accurate refraction, focus the patient first. Start with plus 1.5 diopters in the phoropter, then take away the plus in quarter until the patient reaches the 20/20 line. This is the real refraction you are going to work on. So I'm going to stress on these lenses that is going to stress on, which is the Technics Symphony, the Zeiss Atrilara EDOF, Atrilara EDOF Toric, and the coming future in Egypt in the coming months, maybe the era of the COVID stopping to reach Egypt. It's a fine Vision Triumph, which is I think it will going to change the number of lenses. So I start by the Technics Symphony, which is giving the patient use a unique relief profile to elongate the focal point, delivering excellent uncorrected visual acuity over a continuous range of distance while maintaining a high contrast performance. Very important to note that the Technics Symphony IOLs increases the depth of focus to increase the range, so it's good for the mesopic and scopic vision. Technics Symphony also reduces the effect and the even correction of the natural abrasion in the phakic eyes. The better light aligns, the sharper the vision. Technics Symphony correct chromatic abrasion as a result of different colored wavelengths focus more closely together and the contrast is enhanced. Technics Symphony, which gives 1.5 for reading, so they maintain the experience for the intermediate, I mean, so it maintains an exceptionally low profile visual disturbance, so the patient with presbyopia and even astigmatism can tolerate. They can tolerate up to 1.5 astigmatism, even if the patient, we don't need to put a Technics Symphony Toric. Technics Symphony, it's a better excellence for performing the light condition, as I said, for mesopic and the other types. The other lens is the Zeiss Atrilara EDOF, which is a diffractive optical design for far dominant light distribution. It gives the average defocus curve of the Zeiss Atrilara show a highest visual acuity values than the J&J Technics Symphony over a wide range of focus distances, suggesting more spectacle independence than the Technics Symphony. The design of the Zeiss Atrilara different. The patent smooth microphase technology reduces the glare that happen with the other lenses. It also clinical results confirm low amount of visual side effects with the patients. We have the Zeiss Atrilara EDOF Toric, which have a wide range of toric lenses from +1 to +4, and also for other design from +4.5 to +12 cylinder. The Toric EDOF has a wide range. It precise for astigmatic correction, and the most important, it's proven that they have rotation stability. The other coming lens, which I am looking forward for it's the Fine Vision Triumph. It's a EDOF lenses with a trifocal technology. It has a lot of things for the quality of vision. It's an edge technology for decrease the negative dysphotopsia. It's decrease the chromatic aberration, so it gives the photopic effect reduction. The pod platform, which gives more stability. The G-free, which gives more safety for the patients, and the trifocal technology, which gives the energy at all distance. The double C loop technology, very important. that make the no sticky haptics, so it decrease the rotation. Also, the pod stability of the 5 Vision Triumph give the high contact for the in the capsule, giving the more high stability. The design of the Triumph is a double C loop technology called the pod LGF, which give more stability in non-rotation. Also, it has two design. They give corrected to the refraction and the diffraction. Refraction for the far and the refraction for near and intermediates. For the refraction, it's called the power red light will be less than the power for green and the power for blue light. So it correct the refraction for the distance and the diffraction for the near and intermediate. Like this, as I said, it's a combination, creates a compensation of the chromatic aberration for the patients. When we compare the lenses, we're going to find that these lenses have the better than other lenses. Fine vision also decreases the negative dystopsia, which is the commonest problem nowadays for most of the patients using a premium IOL, which is a hydrophobic technology. It's less in hydrophilic, which is has many series like the square haptics, the acrylic hydrophobic lenses, the 0.5 millimeter anterior capsule overlying the optic lenses. So in these lenses, it changes. It has a posterior concave radial effect, which decreases the negative dystopsia for these patients. We're going to use this lens. So when we summarize the Triumph, it has a 5 changes in the picture. So it's decrease the chromatic, so it's a decrease the photopic correction, leading to the vision and the quality for the patients. Edge technology, decreasing the negative dystopsia vision quality for the patient. The pod technology, more stability and more long-lasting vision quality. Also, the less PCO for the patient, giving more safety for the patients, and the spectacle independence because it gives for distance and for near for the patients. So I hope this video will going to work. It's not working. So my take-home message is, remember the critical importance of the carefully selecting and matching your patients to the most appropriate IOL. Don't skimp on chair time and make sure you choose the patient with appropriate psychological and clinical profiles. Always remember, there have healthy eyes, in particular healthy tear film, which is very important. Any dry eye should be treated perfectly. Negligible side effect and faster neural adaptation and true EDOF result in more satisfied patients. Everyone should be happy. The patient should be happy, and also the doctor should be happy, the surgeon. Thank you so much, and we are waiting for you after this era in our lovely country, Egypt. Thank you so much.
Thank you, Ashraf, for this nice presentation. And there is a question from the audience, if you can hear me.
Yes.
In your experience, with which of the 3 IOLs the patients are more satisfied? I know that you don't have any financial interest, but from your experience, which one is?
Since I started the Symphony, I didn't have a lot of complaint from the patient, except in the early beginning when I used it with a little bit high astigmatism without the correction, the patient was not satisfied. I always do. I don't give zero post-operative for the patient. I make it less myopic for one eye for the patient. This helps me that the patient gets satisfied with the Symphony. Still, the Triumph, I didn't try it, but I know people to try, and they are very happy with them. Usually use the monofocal, which I put monofocal in one eye and the Symphony in the other eye. Patient becomes satisfied. This is my experience with the IOLs.
The monofocal or monovision trifocal, it's I don't have the experience. Yes, at the old days we were doing the mix and match, but putting one monofocal in one eye and extend the depth of focus of the other eye. How many patients that you did with this?
I did five patients. And I did it according to the counseling with the patients.
Yes.
I did the first eye with the Symphony, and he was very happy for the intermediate distance.
Yeah.
So I told the patient, but the distance was not very good for this patient. So I asked him for the other eye, I'm going to do nearly Imitro for the distance vision.
Good.
So it's using mainly the Symphony as an intermediate distance and the monofocal as a distant vision.
I have experience in one patient with the Triumph post-refractive surgery. So let's not talk about the post-refractive because I think Sergio is going to talk about it. So let's hear him first, or let's see his presentation first before speaking about the trifocal for the post-refractive patients.
Okay.
Okay. Thank you so much.
Okay, thank you so much. So it's my pleasure now to introduce Professor Francesco Carones. He's going to one of the experts in the trifocal technology. So he's going to talk about the trifocal IOLs with the cones and prunes and how we are going to choose which lens for which patients. Your talk with you, Francesco. Thank you for sharing, Francesco.
Thank you so much, Ashraf, and thank you for this very nice invitation. I'm very happy to be here and bring you my insights as regards trifocal IOLs technology. I hope that you can already see my screen.
Yes.
Perfect. I'm going on the presentation mode now. And I will start just disclosing some financial relationships that I have here. And you see that some of them are relevant to this presentation. So let's start from your talk, Ashraf, in pointing out where is the difference in between EDOF and trifocal IOLs. The difference is pretty much in the way that the focal points are generated. And if we start from single focal lenses, the monofocal ones, they just generate a single focal point. Lenses that are generating more than one focal point are called multifocal, and they can be trifocals, bifocals, and they can be either diffractive or refractive, while lenses generated in longitudinal elongated focus are called EDOF, as you explained extensively. And also these lenses may be diffractive, refractive, or they may have like an aperture optics as well. Starting from the concept of trifocal, I want to discuss with you how the diffractive IOLs perform. So we know that these little small optical discontinuities, so-called steps, simultaneously create two very distinct or two or more distinct focal points for distance in near. In the example of a bifocal, or in an example of a trifocal, they generate a distant, an intermediate, and a near one. And here you see how the technology performs with the traditional trifocal IOLs. We have steps that are different in height. So each step directs the light to a distance that is either distance, intermediate, or near, with a potential quadrifocal technology that is not on the market. The focal points can be directed to 4 different distances. Actually, a modification of the quadrifocal technology is what the enlightened technology has been implemented with the Alcon Panoptics, where the distance focus has been implemented by the third order step as to direct more light for distance in the attempt to decrease all the night vision problems and in the attempt to increase the quality of vision for distance. Here is an aberrometry of a monofocal IOL. This is a very sensitive aberrometer from CSO, and you can see here that most of the lens is green, meaning that this lens sends the light for a distance. Let me just put out my mark. So you see here, green, see most of the energy is transmitted for a plano distance. Here is how a trifocal performs. So you see that from the center to the periphery, there is this continuous alternation of steps. Here is one, here's the other, here's a flat area, here is one, here's the other, here's a flat area. This is the profile, the optical profile of the panoptics. And just to have a comparison, here you can see how an EDOF, in this case, the Symphony, performs. You see this waving effect going from blue to red, meaning the focal lengths are elongated and not just in a single distance. So clinically speaking, there is a comparison that has to be made in between trifocal and extended depth of focus IOLs, where the trifocals have the advantage of providing greater spectacle independence and obviously a better unaided vision. But on the other hand, EDOF IOLs have advantages that you can read here, being more forgiving in terms of both getting to plano as well as providing a better quality of vision at night. Here is the defocus curve of my personal cases of the EDOF that I use the most and the trifocal that I use the most. And you can see here very well the differences. So for all the patients where you want to improve mostly everything that it is in between plano to roughly minus 1.5, which means 60 centimeters, EDOF lenses perform better. If you want to give patients more spectacle independence as regards near vision, you see here is where the trifocal performs better than the EDOF lenses. And trifocals actually are not a single one. There are different brands with different technologies. So they all have advantages and disadvantages. Here is a comparison in between the fine vision and the panoptics. Here is again is another comparison in between panoptics, the laser tree and the fine vision as well, just to show you that in the whole world of trifocals, you may really want to not choose just a single one to implant, but maybe choose the one that it's more appealing for the patient's requests. One of the biggest differentiations in the trifocals is the intermediate distance. Just to give you an idea, the panoptics is focused more at 60 centimeters for intermediate. The fine vision and the laser 3 are focused more at 80. So if a patient needs to read relatively closer as regards intermediate, I would go to a panoptics. If a patient needs to be a little bit farther for intermediate, that's a good room for a fine vision or for an laser. Here's with my preferred trifocal, the spectacle independence level that I can give the patients, just to make it very easy. Blue means completely spectacle independent. Obviously, there are cases and situations where even with a trifocal, patients have to use spectacles. But you see how large, how big, how great is the spectacle independence that trifocal IOLs can provide. On the other hand, we know that this kind of technology may impact the quality of vision, certainly more than a monofocal, but also more than an EDOF IOL. So you see here that the percentage of patients actually seeing halos or having night vision problems, either always or quite often, it's still relatively high, and that's the limit of the technology. So why do we have many trifocals and many technologies? Because as I always like to say, there's not an IOL that can fit all patients because all patients are different. And the three key points for presbyopia correcting IOLs, there are spectacle freedom, quality of vision, and reading in the dark, cannot be switched on all the three at the same time. So there is always a compromise that you have to take into account when making the best choice for your patients. And making the best choice for your patients, meaning analyzing through a kind of circle of life, all that goes from motivations, going through preferences, expectations that patients may have, and benefits and compromises that all this technology may provide. So we know that the most common patient preference as the outcome from cataract surgery or refractive lens exchange is to have the widest range possible of vision without spectacles. And here is how the lenses that are on the market perform, obviously the monofocal being the worst and the trifocal and hybrids being the best. And here is what each single of these lenses in terms of category can provide quite systematically. So with the monofocal, what is possible to deliver is obviously only monovision, and obviously the trifocals and the new hybrid lenses can really give a full spectacle independence. On the other hand, the second most common patient preference when dealing with this IOLs is to have the lowest possible compromise as regards to quality of vision and halos and glare. And obviously here in this case, the arrows is this arrow is completely reversed in direction. So going from monofocal IOLs where there is actually no compromise, those lenses performing better are those delivering more compromise as regards the quality of vision. So how do we deal with all of that? The most important point to analyze, to discuss with our patients are the motivations that bring patients helping us making a choice. Because if on one hand, we know that the trifocals give all these advantages compared to all the other IOLs, we know that the trifocals also provide patients with more dysphotopsia, with a little bit lower contrast sensitivity. There is this kind of light dependency for reading, and they are definitely less tolerant as regards residual refractive error. So there are cases where another IOL or presbyopic correcting IOL may be preferred to trifocals, even if patients are really seeking for spectacle independence. And you see here the most common category of patients who may really benefit from a different IOL than a trifocal because of these kind of compromises that the trifocals are providing. We also know that there are eye conditions where we don't like to implant a trifocal IOLs because, as was mentioned earlier, these lenses may enhance the compromises if for any reasons the eyes is not performing well, and the most common conditions that you may want to avoid, you can see and listed here: severe dry eye, cold endothelial gutara. To me, is one of the biggest reasons for not going to a trifocal. But you see here how the reasons for not implanting a trifocal IOL can be more than one. So just to conclude, there is not a better IOL. There is not the best one. So the challenge that we have is matching the motivations of the patients to the compromise and to the performances of the IOL, because we know that the motivations that the patients have to get spectacle independence can generate their idea of preferences, and the preferences generate the expectations that these patients have. So we have, as doctors, try to match these expectations and making very clear what are also the little compromises that each single decision may involve. So our greatest goal is to make this matching in between the expectations from the patients and the results that we can really provide really to have. So I really thank you for the invitation. I'm really looking forward to seeing again all of you live and not through screens. And I really hope that you're going to enjoy this meeting and everything else. So thanks again.
Thank you so much, Francesco. You have a lot of questions.
Oh,
you are yes, you are receiving a lot. So the first question is from our friend Eric Martins. He's asking you, do you have objective questionnaire to determine which premium IOL will be the best for specific patient?
I missed a part of your question. Can you please repeat it?
Yeah, it's from Eric Martins. He's saying, do you have objective questionnaire to determine which premium IOL will be the best for a specific patient?
Yeah, I'm using two different questionnaires. One is the one that you can find also on the ESCRS web page, the CADVID 9 questionnaire, which is validated, and this is the advantage of this questionnaire. To me, it's a little bit not going in all details as regards what the patients may expect from the surgery. So we developed an internal questionnaire that has 15 different scenarios and the classical questions like, would you accept some compromises in night vision if you're going to get spectral independence and all of that? So we are trying really to address the different personalities through these kind of questionnaires as well.
Another question from Nasrallah. He's saying, do you use premium IOLs in vitrectomized eyes?
Well, it depends on the reason. I mean, I don't think that for all eyes that are not normal, we can really draw like statements or rules. Each single situation is different. Let me give you my example. It happened at least on somewhere around 5 patients during my history with a presbyopic retina IOL to perform simultaneously vitrectomy and the implant of a presbyopic retina IOL, where the vitrectomy was targeted at either removing floaters, so a kind of vitrectomy for floaters only, or for removing an epiretinal membrane, very mild, very bland, not significantly distortion. I mean, doing distortion to the macula. In these cases, I feel that presbyopic correcting IOLs can be implanted, although I prefer to use EDOF rather than trifocals.
Yes.
Obviously, if the reason for a vitrectomy is because of retinal detachment with macula off and all of that, I would not implant it.
Another question from Detlef Holand. He's saying, do you use an emmetropic in emmetropic patient? Do you use a trifocal technology?
As for now, only if they have cataract. So I'm not doing refractive lensectomy for getting rid of glasses if these patients are still seeing 20/15 and they have no other signs of cataract or so. At the same time, for all that is 1 or more diopters in the presbyopic age, I'm doing a refractive lens exchange quite extensively.
Okay. Another question. Do you have any, what's your experience in the enhanced technology from J&J?
Enhanced is an interesting lens, but it has nothing to do with a really presbyopia correcting technology, because you can get some sort of good intermediate, especially when using the same strategy that you are using, Ashraf, for EDOF, so leaving an eye slightly myopic, but yes, in terms of the amount of spectral independence that the IOLs delivers, is not enough. So I think it's a good alternative for patients who are really not indicated to presbyopic retina IOLs if you want to deliver a little bit more than what the monofocal does. At the same time, I would never use it for presbyopic correcting purposes.
Another question from Washington, from Dr. Ismail. He's saying he used about 45 of PanOptics, but he's seeing that most of the patients lose 1 line Snellen under mesopic condition. Do you see this?
Well, this may happen using all trifocals, because there is a sacrifice in the amount of light energy that is delivered through the trifocal IOLs. So constant sensitivity, especially under dim light conditions, is definitely decreased. This is the compromise that these patients have to accept in order to get spectacle independence. What I would really want to stress is that there is, at least in my hands, not an IOL that it is significantly better than the others. Everybody of us may end up with a preferred one, but having played with all of them, I don't see any of them being frankly superior to the others.
Okay. Last question. They are asking how many bottles of wine you have behind you.
This is to celebrate as soon as we finish COVID lockdown.
Thank you so much, Francesco. It was a very nice talk and very experience from your side. Thank you so much.
Thank you.
Now I'm going to invite my dearest Arthur Cummings. He's one of the pioneers in refractive surgery worldwide. He made a lot of changes in this field, and a lot of students was under him. I am one of the fans of Arthur Cummings. So thank you so much for accepting my invitation, dear Arthur, to be with us. He's going to talk about how to use premium IOLs in post-refractive situations.
Thank you, Ashraf. Thank you for your very kind introduction. That's very kind of you. You're too generous. So I'm going to speak about premium lenses in the post-refractive situation. And I'll just give it a second or two for my talk to load. And Ashraf, perhaps when you tell me it's loaded, then I'll start.
Okay.
In the meantime, thank you so much for this invitation. It's so nice that despite coronavirus and the fact that there are no flights, we can actually meet like this. It's very helpful.
Yes, we cannot stop from meeting. We are used for this for a long time, and nothing can stop us, even unknown, unexplained virus.
Yeah, ophthalmologists enjoy learning. Are my slides not there yet?
Yes, perfectly.
Ah, fantastic. All right, so thank you very much for this invitation.
Thank you.
I'm speaking about the post-refractive situation. Thanks for a very nice event so far. These are my financial disclosures. I'm going to mention Alcon lenses at some point, Vivior and Wavelight. So many patients referred with reduced quality of vision following cataract surgery show the following findings. If you do the HD analyzer, you find that there's some scatter, and often it's due to the cornea or the tear film. If you do wavefront aberrations, you find that the corneal aberrations are more than the IOL or internal aberrations. And then often on topography, you see topographic evidence of small optical zones or decentered optical zones. So many patients who've had previous laser vision correction or RK and are quite happy with the result, one day when you do a cataract operation and you replace their lens with a perfect IOL, the cataract surgery unmasks the corneal aberrations. So patients that have previously undergone keratorefractive procedures and enjoyed the benefits of good uncorrected vision demand similar results after IOL surgery. And basically, there are two options to get them spectacle-free. The one would be monovision or blended vision, and the other would be multifocality or presbyopia correcting IOLs. So my experience was limited to the AcuFocus IC8 pinhole in these particular eyes with aberrations or aberrated corneas. So because I didn't have much experience, I decided to poll 90 expert surgeons from around the world. And some of them are on this panel, and others are probably in the audience. So I polled 90 surgeons, 150 in fact, and within 4 days got 90 replies. And I have 10 questions for them. The first one is, do you use presbyopia correcting IOLs in eyes that have undergone previous keratorefractive surgery? 68% said yes, 32% said no. Well, if your answer was no, why don't you use them? So 48% said, well, the results are poor, that I've tried before. 32% said, I'm not sure about patient suitability. And 16% said, I'm not sure what lens to put into these post-vision correction eyes. Other comments were, it can be possible when there are almost no higher order aberrations present in the cornea, obviously. There's a potential for grading additional visual aberrations. And I don't have confidence in multifocal lenses, even in virgin eyes, with some of the comments. So if your answer was yes, are you satisfied with the outcomes thus far? 55% said yes, 9% said no, I'm not, and the remainder said sometimes. So of those that said, yes, sometimes I am, 47% were happy more than 75% of the time, 41% were happy more than 50% of the time. So 88% have had a somewhat positive experience. So question 4, what are the key criteria to achieve a satisfactory result? So by far the two that were the most important were current corneal higher order aberrations as a result of the laser vision correction, or ocular surface disease or dry eye disease. Other comments that came up is personality and patient expectations are most important, irregular topography. All right, if you've had previous surgery, does it make difference if it was for myopia or hyperopia? 40% said they do better with myopia, 26% said with previous hyperopia, and 34% said no difference. So the question then was, well, for those hyperopic patients where you said it works well, does it make a difference what level of hyperopia they were before their LASIK? 54% said yes, 38% said no. And then the next question was, what is your upper limit of the previous hyperopic correction? And on average, people would be happy enough to put a multifocal lens in for someone who had 3.6 diopters of hyperopia. But you can see that as their hyperopia progresses, people are less inclined to want to put in a premium lens after such a laser treatment. What about myopia? This was a reversal. 60% of patients said, no, I have no issue with how high the myopia was before the time. And looking at the levels of myopia, the average amount that people were prepared to do was up to -6, but there were a good number of people, even at -8 or higher, saying, I don't mind if this patient had laser at that level, I'm still putting in a lens. So it looks as though people are far more accepting of higher degrees of myopia than of hyperopia. Then the next question was about angle kappa. We've heard a lot about angle kappa and multifocal lenses, and 16% said if it's less than 400 microns, 450, I'd like that. 29% said, no, it needs to be less than 500. And in fact, 31% said it doesn't matter. Some comments, it's all about the preoperative discussion. Given the right patient, I would have operated on any angle kappa. I don't routinely check for angle kappa with normal cataract surgery. I never really found a real correlation, although more than 500 microns seems to me a good cutoff not to cross, and not sure it matters. So very interesting looking at this group of people with a lot of experience saying angle kappa may be less important than we thought. Right, on the lens design, which lens design has provided the most satisfactory results in previous keratorefractive surgeries? Not everyone was using the pinhole optic, but of those who were, it was clearly the leader. And then on the other lenses, the next lens was a trifocal, followed by a multifocal, followed by an EDOF. So in these 90 surgeons that I surveyed, pinhole optics number 1, trifocals number 2 in a post-refractive situation. So who are the best and worst candidates? All right, patient motivation is the strongest driver for surgery. The wrong personality is the strongest negative driver. A real cataract, significant current refractive error, stable refractive error, adaptive personality that was happy with LASIK. So here's a real red flag. If your patient was not happy initially with their LASIK procedure, don't think about putting in a multifocal now. And then small aperture IOL seems to provide good results across different refractive areas. The worst candidates, quality of corneal optics, and the patient's personality has to be suitable. So you can see that come up frequently. Here's just an example of a patient with aberrations in the cornea. This is courtesy of my friend Guy Saleh. And you can see the higher order ablation profile that the laser wants to do. So this doctor decides to first go and correct the cornea. You can see the way that topography has improved. And in fact, so did the patient's vision to such an extent that the cataract surgery was delayed. So in any of these patients with cataract symptoms, always have a look and see how much the cornea is contributing to the visual quality. I want to share, I'm not a consultant for AcuFocus, but I want to share you this quickly. They did an interesting study where they looked at market share when they introduced it to Australia in 8 very different sites. And what they found is initially almost 16% of these IOLs were put into eyes with previously treated corneas or irregular corneas, and satisfaction was very, very high. So when you looked at the irregular corneas, most eyes were getting monofocals and then monofocal torics, but then the next lens that people were using was the IC8 before they were using other lenses. And you can see of all the other lenses, even in Australia, the trifocal was used more than the others in the post-refractive scenario. And so IC8 share seems to be growing even in the normal eye. So there are two main factors. The eye is one, we've just seen those. And then the second one that I want to speak a little bit about is the patient. The right personality needs to be easygoing, needs to have been very satisfied with the previous laser vision correction procedure. And we need to manage expectations, as has been said very eloquently by Francesco a moment ago. So the tools that we can help select the right patient for a particular solution. We use contact lens trials quite a lot for blended vision, monovision, or multifocality. Obviously, they're not that effective for someone with a dense cataract, but with lower degrees of cataract, they're possible. And then we've also started using a lot of objective visual behavior data, generating personal defocus curves and a lifestyle match index. I'll show you what this is now in a moment. So typically, we've made these decisions with questionnaires, with in-depth interviews. We're using a device that fits on your glasses by a company called Vivio. I'm a consultant for them. And this device measures working distances that then presents you with a personal defocus curve. It looks at the lighting situation that you were in, and it looks at your head position. So it gives you a lot of information about your visual behavior. And in fact, on the movement orientation, it can pick up so much, the algorithm, that actually knows what you were doing. It would know whether you were looking at a PC versus the laptop. It even can see the angle of the object you're looking at. So you then present it with something like this, the defocus curve on the left, and this matrix on the right that shows you that for this patient, they're spending 25% of their time at distance, 48% at intermediate, 27% at near. If you look at it horizontally, you'll see they're spending 46% of their visual behavior is in good light and 15% in lower light. You can then look at what the data looks like over the few days they were wearing it. Does the weekend look any different to the week? And now here's a tool that I'm finding amazingly useful. We've only had this for the last couple of months, but this really helps the patient make a decision. So on the page here is the patient's defocus curve, and the bars that have been shaded are what the vision will look like with a generic monofocal. So I can tell this patient, if we put a generic monofocal in, they're going to be free of spectacles for 21% of their day, but the rest of the time they're going to have glasses. If I implant for them a generic multifocal with a +3 add, it's going to add 20% functionality. Then I'll be seeing in the distance and also up close. But for this particular patient whose lifestyle involves a lot of intermediate, they still need glasses for a number of things. If you put in a 2.5 multifocal, that gives even more functionality. If you put in an EDOF, more again, we've now added 44% functionality. And if you put in a trifocal, now suddenly we've really added functionality. So what this device allows us to do is look at exactly what the patient's lifestyle is and then match it to any lens you like. Every single lens on the market that is a published defocus curve has the is in the library. So in the majority of lifestyle that we've tested with 500 eyes, the trifocal comes out as the most common fit. There are 25% of cases at least where an EDOF is a better option. And typically when patients see the benefits like this, they tend to request a presbyopic correcting lens. So the patient advantages are that the data is objective, it better reflects their requirements than subjective data. They really feel that their personal needs are being considered. They feel that the surgeon has a greater interest in their outcome. They feel that they're being heard and that they're playing a role in the IOL selection. And they also feel that because the objective data is more accurate than subjective data, my reading might be a different distance to your reading, for argument's sake. From the surgeon side, patient satisfaction increases. There's a better workflow. You can make better decisions, quicker decisions, and patients become a little bit less demanding when they understand, because when they see this exercise, they really understand those compromises Francesco so eloquently described. I want to share with you just as my last slide, just this book. It's called Invisible Women, and it's a book that if you haven't read is very interesting. It's about one of the chapters is about clinical trials. And it just shows you how most things in the world, like seatbelts or rucksacks or backpacks or chairs or anything like this, are normally tested on men, and then the data is simply extrapolated to women. And clinical trials are very, very much the same. So clinical trials are often done on healthy young males, and then once the pharma product has been approved, then they start extrapolating how it might work in women or older women. So this book really brings to mind that even with IOLs, of course, women and men are going to have different needs. They are different sizes, different areas, different needs. So it's a win-win scenario having so much data. So to end, up until relatively recently, using a presbyopic correcting IOL was contraindicated in eyes that had undergone previous keratorefractive surgery. But this is clearly no longer the case. From the 90 opinions that I got, corneal optics and ocular surface are key. Patient personality is very important. And it may be that the pinhole optic is enjoying the best results at the moment, but people are reporting good results with all of the presbyopic correcting IOLs. So thank you very much for your attention.
Thank you so much, Arthur. It was a very nice, interesting presentation, but you have a lot of questions.
All right, that's good. I'm happy enough. Let me just get
yes,
back.
the first question, they are asking about the Viper, and it's a very nice instrument. When it will be commercialized?
It is now commercialized, so anyone who's interested can contact Vivior. The address is vivior.com, and they have a very good package where they send you out 10 of these devices. They can be reused. They send them out at no cost. There's a startup cost, and then for every report that they generate for you, there's a fee. My patients have had zero pushback on the fee. It's $100. And the conversation I have is when a patient says to me, the cost of the lens sounds a bit expensive, I'd say, well, no. The cost of the lens is actually very, very reasonable. It's 5 times less expensive than a hearing aid, and people are getting new hearing aids every 4 years. Why I want you to do this test is not because of the cost of the lens. It's because of the fact that this surgery gets done one time. So I want to make the best choice for you with your data helping me decide what the best lens is for you.
Very nice. Another question. Do you see that if the patient is under refractive surgery for a long time, if there is a difference in the abrasions in both eyes, this makes you choose different trifocal or EDOF lenses according to the abrasions you're going to see in the patients after refractive surgery?
That's a very, very good question. So I'd find that question very hard to answer unless I had a device like the iTrace, or a device like the KRW1 from Topcon, or a device like the OPD3 from Nidec. And so I have the iTrace, and on any of these patients, I'll always do an iTrace to see which is playing the biggest role. If the lens is playing the biggest role, I'll base my decision on the lens choice for the IOL. I'll base it on Vivior. If the cornea is playing the biggest role, I will in fact first correct the cornea with a topography-guided treatment to improve the cornea. Now, I want to ask Francesco himself, because I think he was the first person in Europe to use the Vivity IOL, which is a new range of EDOF, but it's so different to an EDOF that they're calling it a wavefront shaping lens. And I've used this lens in a few post-refractive cases. And this lens has the same dysphotopsia as a monofocal, the same dysphotopsia with a very wide range of vision, significantly wider than the current EDOFs. So I'd love to hear Francesco's comments later in the discussion. So I think that lens is going to start playing a very big role in especially post-refractive eyes.
Okay, another question from Detlef. He's asking, in the cases of myopic cornea refractive laser surgery, do you use a Monovision for these patients?
So I'm a very big fan of Monovision, Detlef, and if the patient had Monovision before, I'm not only going to go through the path of even looking at a multifocal. If they've been happy with Monovision, I have Monovision, and I've had it for the last 10 years. So by the time it comes for me to get cataract surgery, I'm not going to think about a multifocal. I'm going to go with a monofocal lens because I've got so used to Monovision. So I'm going to leave these premium lenses for someone who had laser vision correction done before and received emetropia and didn't like the idea of Monovision.
Okay. Thank you so much, Arthur. We are waiting for everyone in the last to have a conversation between us all. So now I'm presenting one of my dearest friends that we are in contact since the last 2 years, Sergio Canabrava from Brazil. He's a very talented surgeon, and he has a lot of innovations. I'm very happy that he accepted my invitation to be with us. So come on, Sergio. He's going to talk about a very interesting topic, the hybrid mono vision with the trifocal IOLs. A lot of questions is coming also to ask about what's hybrid IOL. So it's the talk with you, Sergio. Sergio, you are here? Hello, Sergio? Sergio? So till Sergio come on, I'm going to ask Arthur another question coming from the audience. Arthur, are you here? Sergio is still here? So I can see you, Sergio. Can you connect, please? Sergio.
Ashraf, can you hear me?
Yes, Arthur.
I think
there is.
Yeah, I think the internet went down for a while, it looks like.
Yeah, I think so. So there is a question for you. They are asking how you select trifocals in post-hyperopia and myopic LVC.
So I would first do the eye trace to make sure that the lens is the bigger aberration, and I would then use Vivio to help me decide what the patient's needs are. So in a hyperope who had a high level of hyperopic correction, like a +3.5, +4, I would probably put in a monofocal lens into the first eye. And often in these eyes, you find they get much more reading than you would anticipate, even if they achieve emmetropia, because of all the positive spherical aberration in the cornea. And then depending on how much they can read on the second eye, you might only have to aim for something like -050 or -075, and you'll get enough reading. But as I said to you earlier, I think this new wavefront shaping lens, I think is going to give us very big application in these post-refractive eyes.
Another question, he's maybe a resident. He's saying, as a beginner surgeon, I have a question. After LASIK, the eyes should be aberration-free. Should we implant an aspheric IOL or spherical IOL? Does this make a difference?
It does make a difference, but after laser, the eye is not aberration-free, unfortunately. That's what we target, but it's not what you get necessarily. And if you're doing something like wavefront-guided laser, you're trying to make the eye aberration-free, but in the process, you would have induced some sort of corneal aberrations to address the ocular aberrations. So I think any eye that's had a previous corneal procedure, it makes a lot of sense with whatever device you have, but to try and analyze the quality of the cornea. And all of our topographers and the tomographers have the ability to show you corneal higher order aberrations. So I'd go and look at those. And if those are more than 0.4 microns, be aware of a multifocal lens in these eyes.
Okay, this is a question for Francesco. Can we put Francesco? Yes, with he's asking, can we add, if there is an lenses can be a multifocal or trifocal on top of monofocal for the patient?
That's a very nice question, and there is a huge world to explore with it, because I think that in a perfect world, we should not implant a single IOL. I think that in a perfect world, we should implant a perfect monofocal IOL, and having some add-ons or piggyback options to be adjusted and also maybe changed in future as our life, our patient's life is going to change. So the idea of, especially for challenging cases, starting implanting a monofocal IOL to see how the patient is doing, and then implanting either a presbyopic correcting or a toric in those cases where the astigmatism maybe is irregular and all of that, it's going to give us the possibility and the opportunity for fine-tuning the results and also having a way out for complicated cases when patients are not happy with the results. So I definitely think that this is going to be more and more applied in future as an option.
Okay, another question to Arthur. What is the impact of pupil size when you consider presbyopia IOL correction after refractive surgery?
That's a really good question, because we always think about pupil size with laser vision correction. The fact that the lens is at the nodal point of the eye, it's far less important. The second thing is the people we're doing these surgeries for are older people whose pupils are normally smaller. So to date, I'd love to hear other people's opinions, but I've not seen an issue with multifocal IOL because of pupil size. I've seen
Can I make a comment?
Of course.
Yeah.
I would see I had seen relatively more problems for those patients who lost their pupil dynamics exactly after, rather than having large pupil size when implanting presbyopic correcting IOLs. So the biggest advice that I would give as regards pupil measurement for presbyopia correcting IOLs is to make sure that the patient has some dynamic. It's not like a patient has 2 millimeters of scotopic and photopic, because this patient is not going to take the benefit from the IOL. With some IOLs, especially for all those refractive IOLs where the center part is focused at intermediate, those patients will never reach a satisfactory distance vision. That's the most important point.
While we are waiting for Sergio, another question for Detlef. Can we have Detlef with us? Detlef, can you come, please?
Can you check the pasta?
Yes. Do you hear me, Detlef? Yeah. A question saying to you, if you have a pseudo exfoliation for the patient, if you have a pseudo exfoliation, do you implant toric IOL or not?
If I have pseudo exfoliation, I explain in advance to the patient that it could be that the zonules are too loose to implant a toric IOL. But I think all of us can share the experience that very often in pseudo exfoliation you can't notice any signs of dislocated lens at all or of loose zonula. So then I would also implant a Toric IOL. But it depends on the age of the patient. If it's an older cataract patient, I would, as I told before, implant CTR and then also use a Toric IOL. But if it's a younger patient and it shows also pseudoexfoliation, I would explain that I would go for a standby Toric add-on IOL. And if I would notice anything, I would go for the Toric add-on IOL for the sulcus implantation.
Question for Francesco. Assuming non-complicated phaco, are Tamsuline patients contraindicated for trifocal or multifocal?
Not really. I mean, I haven't seen significant, losses of pupillary dynamics with these patients. Usually, these patients do not fully dilate, and we know about that. But as soon as they maintain some kind of dynamics, meaning that the difference between photopic and scotopic is still there, like they dilate from 2.5 to 4.5 or so. These patients do very well with all the multifocal IOLs.
Another good question. Again, if you are implanting an add-on IOL, is there a problem with the asphericity of both lenses, like aspheric and spheric lenses? You are going to choose the difference?
For who is this question?
I think this is for you and Arthur.
Arthur, you go first.
Okay, so just as a general rule of thumb, thanks, Francesco. As a general rule of thumb, for a previous hyperopic laser vision correction, you would use a spherical lens because you have enough asphericity in the cornea. And for someone who has had a myopic ablation and you've now flattened the cornea and made the cornea oblate, you would tend to use a lens with more spherical aberration. That's a general rule of thumb.
Okay. Another question is saying, what is better? What is better, IOL hydrophilic or hydrophobic after corneal refractive surgery? Oh, Sergio is here.
Really sorry. I don't know what's happening. I did all tests. Francesco's sorry. I don't know what's happening.
No, nothing. So we are going to answer this question and we're going to go directly to Sergio. What is better, IOL hydrophobic or hydrophilic after corneal refractive surgery? If there is a difference, Arthur?
I think I'd like to ask Francesco to answer this one.
Thank you. No, at least in my hands, the choice for hydrophilic or hydrophobic is not depending on previous laser surgery at all. Whatever you do in the cornea, that's not making any difference in the choice for hydrophobic versus hydrophilic.
Okay, and now we are happy that we got Sergio. Sergio is a very sincere friend for me since more than 2 years now. He's a very talented surgeon. He has a lot of innovations worldwide nowadays. He has a lot of fans from what he's doing. So I am going to present Sergio. He's going to talk about a very interesting topic, and everyone is sending questions. What's hybrid IOLs? So he's going to talk about hybrid monovision with trifocal IOLs. Your talk, Sergio.
Sorry about that. I didn't know what's happened. You did a lot of tests before, and for me it's an honor to stay here, Armia, with you, with Arthur, with Detlef, with Francesco, with everybody. It's a great team. And let's go to start my talking. Sorry again. Let's go. This great team, Francesco, Ahmed, Arsha, Detlef, Arthur, it's a pleasure to be with you and with this team. Today I will discuss about hybrid monovision. Here my financial disclosure. And the first questions that my friend sent me in the Instagram said, what are you doing a premium cataract system?
I can't see your presentation.
Can you see it?
No, I can't see
the presentation. Sorry.
No.
Let me try again.
Okay,
now it's okay. Now, okay, let me see. No, I think it's okay.
No, still I can see it.
Yes?
Yes.
You see?
It's loading, yes.
Yes.
Excellent. Excellent. Perfect.
Yes?
Yes.
Okay. Then today I'll discuss about hybrid monovision plus trifocal IOL. Here is my disclosure about IHL, Madu instruments, Morsher, and a pending patent of new flanged IOL. Okay, the question that I received in my Instagram is, Sergio, what are you doing in a premium cataract session? You do only challenge case. No, guys, I do premium cataract too. And what is my focus? My focus with premium cataract with my patients in my routine. My focus is to avoid patients' complaint. Okay, I hate it. Okay, Sergio, maybe you are too cautious. Yes, maybe. Then I hate halos and glare. For me, nightmare is when the patients came for me and Sergio. I want to explant this IOL. I want to explant this trifocal IOL. Then, based on this, what is the hybrid monovision? The first time I read about hybrid monovision was in this JCRS paper that this paper discussed about monofocal IOL in one eye and a diffractive, bifocal, bifocal IOL in the second eye, the non-dominant eye, using a diffractive multifocal IOL techniques. Is a old paper. Then, when I read this paper, I pay attention in the results. 18.8% report expectable dependence only, and no patient report works vision. Then I thought, oh, let me try it because maybe it solves my problems. Okay, then what's hybrid monovision with trifocal IOL? Is a dominant eye, you use a monofocal IOL or toric monofocal IOL. In the second eye, non-dominant eye, you can use a trifocal IOL, like at Elisa in this point. Based on this paper and in my surgeries, advantage of the hybrid monovision: less photic symptoms, halos and glare, increased visual acuity and uncorrect distance based on two trifocal, bifocal IOL in the two eyes, higher contrast sensitivity. Loss watch vision, and here a table that shows compared between monofocal IOL and LISA 3 panoptics and fine vision based on contrast sensitivity. Okay, disadvantage of the hybrid monovision: worse intermediate near vision, less independence of glass, and worse incorrect binocular reading ability for a long time. And then my patients, when I use hybrid monovision, these patients don't can read for a long time without glasses. Okay, my next topic is, how do I select my patients? I have three steps. Every my steps is exclusion criteria. The basics, like everybody, patient motivation, patient jobs, for example, night drivers, unrealistic expectations, lack of progressive ocular disease, glaucoma, maculopathy. This is all my exclusion criteria. And the number two, aberrometry. I love OPD. You can do it with eye trace, and you can do it in OPD. In my hospital, I use aberrometry by OPD. The points that I analyze in all my patients that want a trifocal IOL is a kappa angle, corneal high order aberration, point spread function, PSF, pupil size, and corneal spherical aberration. Here is the overview of the OPD. This red arrow, you can see the PSF, a bad PSF. If I receive a patient with this PSF, I don't use trifocal or IOL. Number two, high order aberration. Okay, high order aberration, comma. What is the number of the comma do you use, Sergio? Till 0.5 micra, okay, in pupil to 4 millimeters. If you have a comma bigger than 0.5 micra, I don't use. Cornea spherical aberration. You need to know if the cornea spherical aberration is minus or positive to decide about the IOL. The size, the number, bigger than 3.2 millimeters, and the angle kappa. Okay, I will not discuss about OPG here because we don't have time. And here my goals with my patients. Every time I do the first eye, the dominant eye, with a monofocal or toric monofocal IOL. And my goals is, of course, 20/20. If I have an error, I don't use a trifocal in the second eye. In my second eye, I will insert the trifocal minus 0.5 degrees. Okay. Results to now. Now I have only 30 patients. Of course, I need more patients. And my average visual acuity far vision 20/20 -2 and near vision J2. Okay, is the best? No, it's only an option for doctors or for patients that I like to say it's between a traditional monovision and a trifocal in the eyes. Of course, it's a controversial topic, but I like this kind of technique because I really don't like the patient complain to me, oh, Sergio, I have problems, I want to explant the IOL. Maybe I'm so cautious, but I like this and I'm trying to start it.
Thank you so much. Thank you so much, Sergio. We have just 4 minutes left. So can we have all the speakers with us? I'm going to say short questions. One for Sergio. If you are going to do a pupilleplasty, are you going to implant the trifocal technology? Very short answer.
No.
Sergio,
What?
if you are going to do a pupilleplasty, are you going to implant trifocal technology?
I didn't.
If you have a pupilleplasty, are you put a trifocal technology?
I didn't listen, please. Sorry, I didn't listen.
Okay, Francesco, if you have a post-operative surprise, large post-operative surprise, are you using add-on or ICL, or you are going to remove the IOL?
Add-on.
I exchange.
You are exchange, Dr. Ahmed.
Yeah.
Okay. And Francesco, you are going to change add-on or ICL?
Add-on.
Add-on. Arthur?
Add-on.
Okay. Sergio?
In Brazil, we'll try a PRK, we try a refractive surgery, but if a large explant.
Okay, Sergio, if you are going to do a pupilleplasty, you are going to use the trifocal technology?
I really didn't
You
listen.
can't hear me.
Sorry, I think my connection is bad. Sorry, I think my connection is bad.
I am happy.
If you are doing a pupilleplasty, are you implanting the trifocal IOL?
Pupilleplasty?
Yes.
Yes.
No. In pupilleplasty, no.
Okay.
No.
Okay, we have just 1 minute left. I am just going to thank you all for accepting this invitation. It was a really great honor to have you all with us. Giving thanks to Dr. Ahmed Al Masry, Dr. Arthur Cummings, Dr. Detlef Holand, Dr. Francesco Carones, Dr. Sergio Canabrava. Special thanks to Farco Pharmaceutical from Egypt for giving us the chance to make this continuous medical education going through. See you all and stay safe in this time of COVID. See you all soon, so soon.
Thank you, Ashraf.
Right, thank you. Goodbye, everyone.
Thank
Thank
you.
you.
all, guys.
Thanks to all the people watching us.
Thank you so much.
Bye. Thank
Thank
you.
you. Bye-bye.
Bye.
Bye.